which is quite good given that it's a highly refractory group. And so hopefully you'll be able to see this technology here at some point in the future. Now, one of the issues, though, is in the US we have a very odd reimbursement system. So each insurance carrier can decide reimbursement. The government can decide for their patients, et cetera. So just because you get approved by the FDA does not mean that you, in fact, are going to garner reimbursement. And it's the initial step in the reimbursement process. You need it to get the reimbursement. And eventually, hopefully, insurance companies start to pay. And that's what we're seeing now in the U.S., taking the state of California, where, in fact, the largest two carriers are now, in fact, paying for it. Now, a few words about deep brain stimulation, if I might. Deep brain stimulation is a totally experimental kind of procedure, which is on the market in the U.S. for Parkinson's. I don't know, in Saudi Arabia, do you do it or you don't do it? No. So what it involves in the U.S., there have been over 50,000 people with Parkinson's disease treated in the U.S. With deep brain stimulation. You place an electrode in usually the subthalamic nucleus or the substantial nigra, and you hook it up to basically a stimulatory device. This is for patients who have failed on typical anti-Parkinsonian therapy, and you drive then that area. And in fact, patients who are virtually paralyzed can start to walk and do well. Now, little temporal lobe, which forms a circuit with the prefrontal cortex and the cingulate. And you can drive that area or take over the activity of the area. What happens in the depressed person is that area should be relatively silent. It's hyperactive in relationship to emotional stimuli. You can show this on PET scan. You can show this on fMRI. And so she decided to try this, and she tried 6 patients who were highly refractory, and 4 of the patients did well, and they continued to do well going out to 5 years. They then published 20 patients, and they had about 55 to 60% response rate in these highly, highly refractory patients. Here are the 20 patients going out to 3 to 6 years. You can see response rates of about 60%. So worked extremely well, and it seemed to have durability. In the more recent studies, the response rates may be a little lower. In this case, this was 17 patients with refractory bipolar depression or major depression treated at Emory with a 36% of 14 showing a response at 12 months and 58% at 2 years. But notice it's 7 of 12, not 7 of 17. If you do 7 of 17, 5 patients dropped out, you're looking at about a 40% remission rate. Still very high for an incredibly refractory group. 2 companies trying to develop in the U.S. Medtronic, using a different area, using the area at the bottom, which is the anterior capsule, which is commonly used in OCD, obsessive compulsive disorder. And they, in fact, had open-label data showing about a 40% response rate. But in their most recent posting of the poster, they were not showing separation from sham using that site. Others have used the nucleus accumbens. Some have started to use the inferior thalamic peduncle. So there are multiple sites. So one company is Medtronic anterior capsule. The other company is St. Jude, or called A&S, and they are studying the Bayberg site. We are one of those sites for the trial. We've started to enroll 2 or 3 patients. And we will have an answer about that in a large-scale multi-center trial over the next 2 or 3 years. Now, a few more words about some drugs that are available in some places, but not in others. So the approval of a drug in Europe may occur, and the drug may not get approved in the U.S. Similarly, the drug may get approved in the U.S. and may not get approved in Europe. But the 2 agencies are not independent. They do work together. The EMA and the FDA work together routinely. And so they are aware of side effects or improvements that are occurring in various places in the world. So one example of this is a melatonin drug called agomelatine. Melatonin is the hormone peptide secreted by the pineal that cues us that it's time to go to sleep. It increases in the evening before we go to bed. Put it in depressed people, pulse them with melatonin, and at a certain time of day, seem to do better. It seems to, in fact, be involved in neurogenesis or cell survival due to neurogenesis. And there's a recent study showing that melatonin resveratrol combination seems to be effective as an antidepressant, and this was effective in a neurogenesis animal model. Just to remind you, melatonin is stimulated by darkness, inhibited by sunlight. It's a key thing to tell us to go to bed, something that people will take frequently when they travel. And it then has a variety of linkages to the pineal, the supraplasmatic nucleus, etc. This is a paper we published a number of years ago just to show you on the right that melatonin levels in depressed patients are mildly decreased compared to healthy controls. And there's a phase delay in the melatonin peak. So there's some melatonin abnormality in depression. And Serag in Paris developed a drug called agomelatine, which is a melatonin 1 receptor or M2 receptor agonist, as well as the 5-HT2C antagonist. We just heard about 5-HT2C antagonism in certain antipsychotics, such as olanzapine. There are several European studies. The issue here are elevated liver enzymes. There are 2 U.S. positive trials. We designed a couple of these trials for the company. The U.S. is Novartis, but elevated liver function tests represent a problem in terms of the improvement. So just to show you this, these are the 3 European studies. And you can see here the agomelatine is sort of the light yellow, separates nicely from the dark orange, the placebo in each study. We did this study comparing agomelatine to 25 or 50 milligrams against placebo, and the 50 milligrams separated nicely. In the other trial, 25 milligrams separated nicely from placebo. But the problem was that the drug induced transient liver and elevations in liver function tests that are dose dependent, with 50 milligrams being greater than 25. But in Europe, this is not the problem. When you study the patients out at 8 weeks, 12 weeks, the LFT is in fact normalized. But people are so worried at times about potential clinical consequences that have not appeared to be problematic in Germany, France, where the drug has been on the market for several years, that this drug, we may not see this drug either here or in the U.S. And that's unfortunate because the Europeans like this drug considerably. This is the last drug I want to talk a little bit about is ketamine. It has received a lot of press. It's an anesthetic agent often used in veterinary medicine. It's a horse anesthetic, but often used in surgery as well. Commonly used for chronic pain, severe chronic pain. And it's an N-methyldiaspartate antagonist, so it works on glutamate. And it can take a schizophrenic patient and make them more psychotic. If given at higher doses. If you take a depressed person and give them the drug, you get acute antidepressant properties. You get a slight sense of depersonalization as well. This is a paper that Carlos Nemeroff reported on of 18 depressives with refractory depression given ketamine or placebo. And you can see here a nice separation starting at 110 minutes, an hour, 2 hours, and then it continues out to about day 3. Then the ketamine response begins to wane. It starts to go away. By day 7, it's better than placebo, but it's very, very close. They did a bipolar 2 depression study. As you can see here, the difference here was about 3 days. This has kind of led to a spate of centers, pain centers in the U.S., who are also now doing ketamine infusion. We need to do more pharmacocontrolled trials. The big problem here is the 2. One is adequately blind the study given the fact that it uses depersonalization. Sanjay Matthew at the Baylor University is about to important to make comparisons to midazolam, which is a short-acting hypnotic, to see if, in fact, it separates there. He is seeing positive results, I've been told, by him. The other problem is, what do you do after the patient is better for 3 days? You keep giving him ketamine because the drug could be abused, you develop an addictive issue. This drug is a street drug in the U.S. We need an oral pharmacology effective ketamine. Unfortunately, ketamine is available orally. That's a good thing, but it doesn't seem to be effective as an antidepressant. So this may turn out to be a kind of acute treatment, or it may turn out to be a clue about trying to develop glutamatergic agents as antidepressants. They're not there yet, although it's an exciting kind of attention. So I've told you about some of the real problems that we have in terms of the high placebo response rate and fewer new clinical entities being studied. There are efforts to improve the Institute of Medicine, the National Academy, and the states are trying to develop initiatives to have better biomarkers to help us develop better targets. There are ECMP, the European College has held us something to talk about investment in drug development. The FDA has participated in the study that the meeting I led at the APA, the Pipeline Summit earlier this year. The NIH is trying to work, as is ECMP, with drug companies to take drugs that they've discarded, that they're not interested in developing, to see if we can now start to develop them again as treatments for depression or for other uses. So in conclusion, antidepressants development is slowing. We have a high failure rate in clinical trials, there's high cost, but in fact, there are efforts now on the part of the profession to improve and to rectify the situation. So thank you very, very much.
By and large, as you know, patients with bipolar disorder present either in the manic phase or in the depressed phase. And you're all familiar with their manic behavior. The symptoms are listed here. This is what usually gets patients into trouble. They get into the hospital. The other side of their manic behavior is, of course, their depressive behavior. Depression, as it turns out, is a much more serious and difficult problem to manage in the bipolar patient than mania. Mania, although it is dramatic and difficult and is disruptive to families, we're pretty good at treating mania. And with a combination of mood stabilizers, atypical antipsychotics, sometimes benzodiazepines, we're able to treat acute manic episodes relatively easily. About 50% of patients with bipolar disorder will have a psychotic symptom either during their mania or at times during their depressive phase. And I'll talk about that a bit later. I also want to remind you that a sizable percentage of patients present in the mixed state, that they have simultaneously both depression and mania. We used to call this dysphoric mania. So these patients are agitated, hyperactive, hostile, irritable, angry, and also extraordinarily depressed. To remind you about the history of bipolar disorder, it was first distinguished from schizophrenia by Kraepelin in Munich in the early 1900s. And as an aside, there is a tremendous controversy in the field right now that has been introduced by Robin Murray and his colleagues at the Institute of Psychiatry in London. And they have suggested, based on some genetic evidence, that Kraepelin was wrong and that bipolar disorder and schizophrenia are not two separate entities, but actually are related to each other on a disease continuum. And they've done this based on genetic commonalities of risk. They've done this based on some treatment data. For example, atypical antipsychotics are effective in treating both acute mania as well as treating schizophrenia. They've also done this based partly on imaging studies. I personally don't agree with this view that bipolar disorder and schizophrenia are the same disorders. Not in any way, and during the discussion, if you'd like, we can talk about this. So in 1949, John Cade in Australia discovered the antimatic properties of lithium. And lithium remains the gold standard treatment for bipolar disorder. It always bothers me that my psychiatry residents think that lithium is an old drug, that there's no place for it, that we should use newer drugs instead of lithium. The fact of the matter is lithium is the gold standard for the treatment of bipolar disorder, and that many patients respond better to lithium than any other drug, and a small percentage of patients actually respond to lithium and lithium only and require no other drug. This is an exception, not a rule, but very infrequently in psychiatry do we have patients that respond to monotherapy. I probably have 6 or 7 or 8 patients that I've treated over the last 25 years with very severe bipolar disorder that were treated with lithium, had fabulous response, and have remained on lithium all these years. Unfortunately, it has some side effects that we'll talk about. So it was introduced in Australia, then Logan Scow in Denmark introduced it on the continent. It was finally approved in the United States in 1970. And then, as we'll talk about, mood stabilizers were discovered, valproate and carbamazepine, approved in the United States and elsewhere for bipolar disorder, largely for the treatment of acute manic episodes. And more recently, we have come to understand the importance of atypical antipsychotics in treating bipolar disorder. Well, let's take a minute to remind ourselves that bipolar disorder has the highest risk of suicide of any of the psychiatric disorders. It doesn't have the highest mortality rate. That's true of anorexia nervosa. But it does have the highest rate of suicide, even more so than major depression. And 20% approximately of deaths in bipolar patients are due to suicide. And bipolar patients, they don't make gestures, they make serious, life-threatening suicide attempts. In terms of the epidemiology of bipolar disorder, I'll tell you my bias. I think bipolar disorder is both underdiagnosed and overdiagnosed. So there are psychiatrists who you are familiar with. Agapa Kiskel comes to mind, who sees bipolar disorder everywhere. And he has developed classifications of bipolar 3 disorder, and bipolar 4 disorder, and bipolar 5 disorder. And I was standing with him at a meeting, and there was a baby crying, a colicky baby. And he turned to me and said, "Oh, bipolar." I don't think so. So I worry about the overdiagnosis of patients who have a temperament that tends for them to be activated and energetic. On the other hand, many patients, as you'll see, diagnosed with depression actually turn out to have bipolar disorder. So we have both an underdiagnosis problem and an overdiagnosis problem. What's the true epidemiology of bipolar disorder? I would say that if you look at bipolar 1 and 2 disorder together, you're probably talking about somewhere between 1.8 and 2.5% of the population, a little higher than what we see with schizophrenia. Unlike major depression, the gender distribution of bipolar disorder is equal. So women have a propensity for major depression, but in terms of bipolar disorder, equal numbers of men and women. It has a peak onset of action at the same time as schizophrenia in the 15 to 24 year age group, and it is a highly recurrent illness. 10 to 15% of patients will have multiple episodes, more than 10 episodes in their lifetime. And this is somewhat what bipolar disorder looks like. I think it is very useful to discuss the difference between bipolar 1 and bipolar 2 disorder. So bipolar 1 disorder is true Kraepelinian manic depressive illness. Patients go from having episodes of severe mania, with about 50% of them being psychotic, including auditory hallucinations. And these patients, as you know, require little sleep, take terrible risks, get into trouble with drugs and alcohol, are sexually promiscuous, get into trouble with the law, and then they cycle down into very severe depressions, sometimes psychotic depressions. Bipolar 2 disorder have depressions that are just as severe as bipolar 1 disorder, but their manias are never full-blown manias, they are hypomanias. So that they will go for a period of 3 or 4 days, maybe 5 days with a diminished need for sleep, requiring 3 or 4 hours of sleep a night. They're never psychotic. They generally don't get into trouble in terms of their behaviors. Most of these patients like their hypomanias. They never come to you for treatment when they're hypomanic, ever. They come to you when they're depressed. And when they're depressed, the first thing they will say to you is, don't take away my hypomanias. I like them. Just treat my depression. But one of the things I'd like you to remember that I've said is, in spite of what other people might tell you, there is no evidence at all that treatment of patients with bipolar 2 disorder with antidepressants will convert them into patients with bipolar 1 disorder. This is an urban myth. It's simply not true. If you have documented, verified bipolar 2 disorder and you receive an antidepressant, you will not become a bipolar 1 patient. The problem with this disorder is it's really hard to treat the depression, and patients are notoriously non-compliant. So let me review for you, before we go on, the mood disorder spectrum. Here are a group of normal controls, like all of us in this room. We get happy when good things happen. We get sad when bad things happen. But we regulate our mood around the mean. Here are patients with dysthymia. As one of my patients said to me, who has dysthymia, I said, how long have you been depressed? She said, since I was a zygote. That's dysthymia. People that are sort of down, blue in the dumps every day. Not terribly severe, but quite debilitating. Then here's unipolar major depression, where patients go from euthymia to depression. Here's bipolar 1 disorder, Kraepelinian manic depressive illness, from severe manias to severe depressions. Here's bipolar 2 disorder. The only thing wrong with this slide are these depressions can be just as severe. That line should go all the way down here. And then this very little known syndrome, which no one really knows anything about. There are almost no studies of this syndrome. I'm not even sure it exists, called cyclothymia, in which patients presumably go from being hypomanic to dysthymic. And I don't really know whether that is a real entity or not. So patients don't get treated for a long period of time, partly because they're not accurately diagnosed. That's one reason. But eventually, they will come to treatment, particularly in their manic phase, but quite often in their depressed phase. The problem with bipolar disorder is that it unfortunately is associated with other psychiatric comorbidities, including substance abuse, anxiety disorders, eating disorders, and like major depression, it's associated with an increased risk for certain medical disorders, such as diabetes, heart disease, and others. There are medical causes of bipolar disorder, so-called secondary manias, that need to be ruled out in the original differential diagnosis. And that's why it's important to get brain scans on patients with bipolar disorder to rule out epilepsy, hippocampal damage, brain tumors, and a number of other central nervous system maladies. We're seeing a lot more secondary bipolar disorder in the TBI population, in the traumatic brain injury population, in our returning veterans. This data was really quite surprising to all of us. This looks at the prevalence rate of substance and alcohol abuse in bipolar I disorder on the left and bipolar II disorder on the right. And as you can see, shockingly, 60% of patients with bipolar I disorder have comorbid alcohol, drug abuse, or both. And on the right side of the slide, in bipolar II disorder, about half the patients suffer from alcohol or substance use or both. Now, the mixed state is a particularly difficult state to treat. These are patients with dysphoric mania who present, as I mentioned a few minutes ago, with both depression and mania. And these patients, these symptoms simultaneously. It occurs in about 40% of manic presentations. And the reason it's important to recognize it is these patients are the one group of patients that do relatively poorly with lithium. And they do much better with valproate and with atypical antipsychotics. So that's worth keeping in mind. Now, the way we follow the course of patients with bipolar disorder is to calculate their cycle length. And their cycle length is defined as the period of time that elapses from the beginning of one episode to the beginning of their next episode. And obviously, we want the cycle length to be as long as possible, meaning the patients are having few episodes. The problem is that the natural course of bipolar disorder, left untreated, results in patients having more and more episodes over time. So you see every study that's ever been done, including Kreplin's original study, Jules Angst, who's been studying this for 50 years, and studies in the United States have all shown that after a patient has their first episode, their next episode variably occurs somewhere between 35 and 60 months. So that's, a considerable amount of time, 2.5 to 5 years. But look what happens as the disease progresses. So by the time you've had your 10th episode, you're starting to have episodes every few months. And this is what we want to prevent from happening. Now, one of the most important questions that you face in your practice every day is when you see a patient who has depression and you make the diagnosis of major depression, do they have unipolar depression or do they have bipolar disorder? And the question that I'd like you to look at here is how often do patients that are diagnosed with unipolar depression actually have bipolar disorder? So this is a study that Jules Angst did. Only he could do this, having seen the same patients for 30 years in his clinic in Switzerland. And in this mood disorders clinic, in their original diagnosis, 8% of the patients were diagnosed as bipolar, 92% as unipolar. At 30 years follow-up, remarkably, a very large percentage of these patients turned out to be bipolar. Now remember, this is a mood disorders clinic by one of the leading mood disorder investigators in the world, so he would probably see a greater percentage of bipolar patients. Having said that, that's a big number. And if you diagnose someone with unipolar depression and they really have bipolar disorder, then you have a real problem in terms of their treatment. Let's look at some other data. This was a study done by Joe Goldberg in New York City in which he followed 74 patients that were initially treated in the hospital with an episode of unipolar depression and followed them for 15 years. And you can see, it's pretty remarkable, that more than a quarter of the patients turned out to have bipolar II disorder. And you can see that right here. And about a fifth of the patients actually had a full-blown bipolar I disorder, which means that almost half of the patients hospitalized with unipolar major depression turned out to be bipolar. The other finding he made, which is really important to keep in mind, is of the patients who were diagnosed with psychotic depression on their index episode, 80% of them went on to have bipolar disorder compared to only 34% of those without non-psychotic depression. And so that means that when we see patients with an episode of psychotic depression, we should be thinking that there's a very high likelihood that they're actually bipolar. This was a study done in France in a primary care setting where primary care physicians, in a psychiatric setting, where physicians diagnosed patients with major depression. And again, you can see that more than a quarter of the patients originally diagnosed with major depression, unipolar subtype, turned out to be bipolar. And here's the study I was thinking about in primary care settings, in which 650 patients were treated for depression, diagnosed with unipolar depression. Turned out a fifth were actually bipolar. So this is a problem for all of us. That means that all of us have patients in our practice who we believe have unipolar depression, but in fact actually have bipolar disorder. Now, how can you help with making that diagnosis when you have a patient before you with major depression? First and most important is you have to talk to their family. When I was originally trained in psychiatry, I was told you can't talk to the family, that will contaminate your treatment. Well, that's really silly. It's important to talk to the family to see if there's two issues. One, is there any evidence of bipolarity in their past behavior? Hypomanias, manias. And secondly, is there a family history of bipolar disorder? I told you earlier that bipolar disorder has the highest genetic heritability of any psychiatric disorder. So if you see someone with major depression and they have a family loaded with bipolar disorder, there's a reasonable likelihood that they are bipolar. They may not have had their first manic episode yet. Those are the most important issues, obviously, other than doing a great evaluation. We already talked about the importance of medical testing and the importance of ruling out medical causes of psychiatric disorder, of bipolar disorder, in particular neurological causes. And we can talk about that during the question period if you'd like. But here's the real problem with treating bipolar disorder. Quite frankly, that has to do with the balance between mania and depression. Because as you know, for patients with bipolar I disorder, treatment with some antidepressants has the propensity to switch them into a manic episode. So as physicians, we care about our patients. We want our patients to do well. We don't want them to suffer with depression, but in our haste to treat them, if we treat their depression too aggressively in certain ways, we may switch them into a manic episode. And it's this balance I'd like to focus on. So our goal is to render the patient euthymic, take that wide, very wide mood variation they suffer from mania to depression, and shrink it down as much as possible to prevent suicide and to maximize adherence to what is usually a pretty complicated medicine regimen. You all know how difficult bipolar patients are when we prescribe 4 or 5 or 6 medications with different schedules. The chance of them sticking to those schedules is very, very small. So this is the sort of timeline for the treatment of bipolar disorder. ECT, still a very effective treatment for severe intractable mania and severe intractable depression associated with bipolar disorder. I highly recommend the use of ECT in refractory cases, and I have many of my patients that it's been life-saving. We've treated a number of women who were pregnant and were concerned about medications with ECT because it was a medical emergency. We were concerned about the health of the unborn child. Lithium, introduced in 1949, followed by typical antipsychotics. And we all know, those of us who are as old as I am or older, will remember that typical antipsychotics are quite effective in treating acute mania, haloperidol, chlorpromazine. The problem with typical antipsychotics is that they are associated with a devastating side effect, tardive dyskinesia, and bipolar patients are more susceptible to tardive dyskinesia than schizophrenic patients are. So one has to be extremely careful about prescribing typical antipsychotics to bipolar patients. In the 1970s, two anticonvulsants were introduced, valproate and carbamazepine. We'll talk about the evidence that they're effective. And then clozapine, the drug associated with a successful treatment of refractory schizophrenia, was discovered to also have efficacy in refractory mania. And that led to the use of all of the other atypical antipsychotics who are all effective in treating mania, and some, as you'll see, are actually also effective in treating the depressive side of bipolar disorder. So technically, those antipsychotics, which we would include quetiapine and aripiprazole, would be classified technically as mood stabilizers. Traditionally, we have limited the use of the word mood stabilizer to the anticonvulsants. But mood stabilizers are really drugs that treat both depression and mania. Let me be clear about the anticonvulsants that are listed here. In spite of their amazing amount of use, the only anticonvulsant on this list, or any list, that is effective in treating bipolar disorder is lamotrigine. It's effective for preventing depressive episodes associated with bipolar disorder, and some of us believe it can be effective in treating the depression associated with bipolar disorder. Lamotrigine is not effective in treating mania at all, not acute mania, and not preventing manic episodes. None of these other drugs are effective in treating either mania or depression associated with bipolar disorder. Not topiramate, not oxcarbazepine, trileptal, which is a drug that's often used, for which there are many failed trials, not gabapentin, not dilantin, diphenylhydantoin, not a variety of other anticonvulsants. So the only anticonvulsants, as you'll see, that are even helpful as adjuncts in treating mania are carbamazepine and valproate. So this is the sort of pharmacopoeia you have available to you. There is a place for benzodiazepines in the management of mania, both in acute mania in conjunction with atypical antipsychotics and mood stabilizers, and also in periods when patients start having a bit of a sleep disturbance, start having what we call roughening, periods when they might have a manic episode, but they're on mood stabilizers or antipsychotics, and they're doing pretty well, but they start getting a little agitated and start sleeping a little less well. You can use drugs like clonazepam during those periods. So this is data from the United States on the number of medications that patients are receiving with bipolar disorder. And as you can see, it's a big number, so that more than half of the patients are actually receiving 4 or more medications, and many are receiving 5 and 6 and even 7 medications. And it's really hard. You know what it's like when your doctor prescribes a medication for you, and you have to take it more than once a day. You know what happens. You take it in the morning, you might take it at night, but you forget your dose during the day. Think about being